my co-host Imran Yusuf, who is a PhD candidate and an ophthalmologist at Oxford University, United Kingdom. I would also like to take the opportunity to introduce our expert panel today. We have two remarkable ophthalmologists who are experts in their fields with us. Professor Filomena Ribeiro, who is the head of Department of Hospital de Luz, Lisbon, and Dr. Nick Reus from Amphia Hospital, Breda, the Netherlands. Thank you very much for being with us tonight, and we look forward to hearing your opinion. Today we are going to be discussing this particular paper, 10-year safety follow-up and post-explant analysis of an anterior chamber phakic IOL by Thomas Conan and colleagues. I would like to share some housekeeping slides before we start. If you haven't joined us before, all the participants apart from the panelists and the host will be muted throughout the session. However, we do encourage interactions. There is a Q&A button at the bottom of the page, so please do ask questions and we are going to present as many of them to our panel as possible. Also, there will be some interactive polls, one of which is coming soon. And I would like to remind you that you can find a recording of today's iJournal Club along with the previous episodes in ESCRS Facebook page and YouTube channel. I would like to give the word to Imran for our poll questions right now.
Thank you, Basak. So good evening to everyone. Welcome to this latest iJournal Club. So we have a few questions. We'd like you to vote on these questions. Obviously, they're relevant to the paper. So question number one, does your clinical practice involve phakic IOL implantation? Two options are yes, you implant them. Two, you see patients who have them implanted. Or option three, you don't typically see patients with phakic IOLs. So this is all phakic IOLs we're talking about now. So do cast your vote. All right, so we have the results. So 20% implant them, 20% see patients who have them implanted, and 60% don't typically see patients with them. So it's useful to know that. Have you encountered this particular type of angle-supported phakic IOL that the paper talks about? Quick question, yes or no? We expect most of this to be no, so 80% is no. We expect that. We've got a young audience generally, I think. And a final question here. Do you think that robust international reporting systems, independent of manufacturers, exist for devices used in eye surgery? So this is about reporting adverse consequences of any device. So see what you think. Yes, no, or not sure. Okay, well, that's very interesting. So nobody thinks that there are robust reporting systems for this sort of thing. 60% said no, and 40% weren't sure whether they were. So that's something we'll talk about soon. All right, Basak, I'll hand back to you for a summary of the paper.
Thank you very much. We really had interesting answers to our questions. Now, before we start our discussion, I would just like to briefly summarize the paper. As I said, we are going to be discussing 10-year safety follow-up and post-explant analysis of an anterior chamber phakic IOL. So here, the authors conducted a non-randomized observational open-label study to assess the safety and efficacy of Acrisov K-shaped phakic IOL. 1,123 patients who received this IOL during 4 previous clinical trials from 35 sites of 7 countries were enrolled. Outcome measures were central and peripheral endothelial cell loss, cell density change, risk factors for endothelial cell loss after explantation, as well as visual acuity and adverse effects. This is the Acrisov K-shaped phakic lens. It's a single-piece foldable angle-supported anterior chamber IOL made of hydrophobic acrylic. This lens comes with 4 sizes between 12.5 millimeters to 14 millimeters, which allows the lens to fit in different anterior chamber diameters. And in 2014, sales of this IOL was voluntarily stopped due to an increased risk of endothelial cell loss. This is the demographics of the patient group. And this is the central and peripheral endothelial density change from 6 months baseline. The top figures represents all of the cases, whereas the figures on the bottom represents a comparison between different models of the lens. According to the study, Asian patients and eyes who received smaller lens models had lower endothelial density postoperatively. Also, there was a significant difference between the mean anterior chamber depth of the explanted and unexplanted group. Explantation of the IOL was performed in 10% of the eyes. 67% of these explantations were due to endothelial cell loss, as I said. Actually, 60% of the patients with low endothelium didn't undergo IOL explantation, and the decision was made according to the wishes of the patient as well as medical judgment of the doctor. Figure on the left is the endothelial cell density change before and after explantation based on different reasons for explantation. And the figure on the right represents the endothelial cell loss rate post-explantation based on different reasons. Sorry about that. As you may see, when the reason for explantation is low endothelium, the rate of endothelial cell loss decreases numerically. But when the reason for explantation is any other reason than the endothelial cell loss, like cataract or synechia, only in 30% of the cases, this is the corrected distance visual acuity of the explanted and unexplanted group before explantation. The corrected distance visual acuity was stable in all eyes throughout these 10 years, whereas the uncorrected distance visual acuity was only stable for eyes which didn't undergo explantation as expected. These are the ocular adverse device effects by different models. As you may see, the most common ones are corneal endothelial cell loss, IOL extraction, iris adhesions, pupillary deformity, and device dislocation. The authors state that they have noticed a trend for higher endothelial cell loss in patients with smaller eyes implanted with L12500 model lens, and also in Asian patients. As you may see, these adverse events were more common with smaller lens designs. These are the serious adverse events by lens model, again, more common with smaller lens designs. And finally are what was known and what this paper adds box. It was already known that there was an increase in endothelial cell loss rate, which may necessitate IOL explantation with Akrusov-Cachet lens. By this paper, we learned that the rate of endothelial cell loss was reduced in some eyes which had explantation. This reduction rate was higher in eyes where the reason for explantation was low endothelium. In addition, we also learned that the corrected distance visual acuity remained stable in all eyes with this lens. Thank you. And also, as always, we have a recommended reading list. If you're interested in reading about phakic IOLs, here are some recent papers from the literature that you may check. But you may also would like to read further about the pathogenesis of endothelial cell loss after anterior segment surgery. So here are some reports from the recent literature. We are very lucky to have a panel like this with us to discuss this paper. So I would like to give the word to Imran to start our discussion.
Thank you very much, Basak. It's really well presented there. Just remind everyone participating, please ask questions. So there's a Q&A button. So if you can ask, type in your question, we'll pose it to our expert faculty here. So I thought it was a very interesting paper, lots to talk about. One of the most interesting figures I just want to talk about first, and perhaps Professor Ribeiro, perhaps I could ask you first. Basak showed a figure that showed the rate of endothelial cell loss before explantation and then after explantation, showing that the rate of annualized loss had decreased after explantation. Two questions really. One, do you think is it logical that that would occur? And B, the figure doesn't seem to imply there was a loss of endothelial cells at the actual explantation, because the graft doesn't really drop at that point where that procedure took place. So let me know your thoughts on that.
Well, I think this paper brings this good news for us that if we follow these patients, it's very difficult sometimes to follow these patients. They are very happy patients with the quality of vision they have, and it's very difficult. So it's something that you should always, in the pre-op, mention to the patient the need to do this follow-up. But it is a good news because this kind of IOL is not now allowed to implant, but we still have to follow these patients and to know that if we can have the rules of a good follow-up, in the case of explanting the lens, we have a clear reduction of the rate of the endothelium cells lost. And I think this is the great news that this paper brings to us. Of course, is not a sudden follow of the rate, we know. We still don't have a good notion of the causes of this endothelial damage, and we are still learning about that. Right now we are facing the nutrients to the endothelium could be a cause for this, and maybe in a already damaged endothelium the recovery is not possible, but the rate is slowing is very good news.
Dr. Reus, do you have an opinion on that? What are your thoughts about that? About the difference in endothelial cell loss rate with explantation?
Well, I agree that what I think is it's not a sudden loss of endothelial cells. It's a gradual decrease in cells, and I think that's an importance that you follow up these patients. And I agree with Professor Ribeiro that it's sometimes very difficult to follow up these patients. Also, because it's difficult, who will pay for these visits? I mean, people tend to pay who will pay for the follow-up over the years. But nevertheless, I think it is important to follow up these patients because you do see a gradual decrease in these eyes. And based on the number of cells that they start with and the rate of progression of their endothelial cell loss, you can decide whether you would like to take the lens out or not. And what this graph also shows is that if you take them out, that on average you decrease the rate of loss of endothelial cells, and that's a good to know that what you do in these cases, that it's helpful on average.
Yes. Okay. Would you obviously this paper is quite useful for following up these patients in general because it gives us quite accurate data on the natural history of what happens to these patients. And I can understand these patients, clearly the paper also says they do very well in terms of their refractive outcomes. They don't have a comparison group, but generally the lens seems to be quite an effective refractive implant. So I can understand the difficult situation a clinician might be in if a patient comes, say the endothelial cell count might be just less than 1,500, they're happy with their vision. It's quite a difficult position to be in as a clinician because if you leave them as they are, they're going to be pretty much as they are for probably a few years or many years, we don't know. And B, if you do something, although you reduce the rate of decline, they may end up possibly even worse, if you touch them. So what do you do? What would you do in that scenario? Dr. Reus, why don't you go first?
Well, that's an excellent question because it's very difficult to answer that. And it often comes down to what would you do with your eyes? And it depends on various factors, of course. I mean, it also depends on the age of the patient and the refractive error. I mean, if you take out, I mean, they chose for such a lens because they wanted to get rid of their glasses and their contact lenses. So just take out the lens and do not do anything else. I don't think that's an option in most people. So, but if you do a refractive lens exchange, in these cases, you have to be aware of a very high, in the myopic patients, in very high risk of retinal detachment in the upcoming 10 years. So that's also a risk for bad visual acuity. So you have to decide by a patient case what to do. I mean, I think it's logical to take such a lens out, but it depends on various factors indeed.
Yes. Yeah, and that reflects one of our comments from our audience members who asked whether the explants were combined with phaco and IOL or another procedure. I don't think the paper makes it clear that that's what happened. But nonetheless, clearly that's the same thought one of our audience members had, that, you know, clearly these patients had the original surgery for a reason, and so you'd have to sort of address the underlying refractive problem as well. Professor Ribeiro, what are your thoughts on that? So obviously it's a difficult situation as a clinician.
Very difficult situation to deal with. And again, I insist, it's necessary that in the pre-op, all is being clear to the patient that could happen, and the need of explanted lens could be possible in the future, because the person is happy with the vision, does not feel anything, has to go through another surgery. Is very difficult to explain and demands a lot of time with the patient to explain everything.
Professor Ribeiro, can I ask you a question?
Yeah, of course.
Have you ever explanted such a lens and then put in a phakic ICL in such eyes?
Yes, that happens in one patient. In one eye had LASIK and the other was implant Akasha. And he heard the news in the television about the IOL and wanted to explant the IOL. It was not, the reason was not the cell loss, but it was the panic of the patient, so we did that.
So do you think that's also a viable option to replace that lens with another phakic IOL, like an artisan lens or ICL?
We should always understand that any surgery causes a loss of cells. So a second surgery will cause the same. It's true that the posterior segment phakic IOLs don't have so much this problem. They have also a lot of cells. We have right now review all our cases, and in 10 years we have in average 5% of cell loss with the ICO, and all models, not only the last one. So it's pretty safe, I think. But of course it is a balance between all the biometric parameters of the patient and the individual count, of course.
Which begs the question, what do you think the safe threshold is? Is there a safe threshold? The annual loss of endothelial cells? Because if, as you say, the ICL is a 5% over 10 years ECL loss, and this lens is a 17%, do you think there should be a safe kind of standard for these sorts of implants, or any implant, when it comes to ECL?
There is an ISO ophthalmic implants, and should be less than 2% of annual loss.
Okay, less than 2% annually. Okay. Basak, do you want to weigh in with some questions?
Yeah, I would like to do so. Actually, we have a question from the audience. First of all, I would like to address that. So I would read the question, and if Professor Ribeiro or Dr. Reus, which of you would like to answer it, please do so. So one person from the audience asked that, do I understand that cachet was taken from the market while the endothelial cell loss is comparable to that of the Artiflex posterior chamber IOL? And was the removal from the market justified to the panel as an opinion?
Well, Nick,
panel's opinion, sorry about that.
No, go go ahead. Just wanted to say that this is a question from Maurits Joosse, who is an expert in artisan lenses.
Well, it's an expert question.
Go ahead, Professor Ribeiro.
No, as I said before, I think these IOL suffer the influence of the bad reputation by eye care that had a greater loss of endothelium cells. And of course, the reason was that the first studies, it was about 3% of annual loss, so it passed the 2% that it should. Of course, there was a lot of problems at that time with all the studies, because it's difficult to standardize the measurements of the endothelium cells. I think it suffers also the influence of several studies without standardizing measurements that could be a factor to the earlier release of this IOL, I think.
And
Yes, because Yes, because it's interesting that indeed the latest. I mean, in the Netherlands, where I come from, artisan lenses, the IRIX fixated lenses are well, they were invented in the Netherlands by Jan Worst and very regularly used. Recently, from Leiden and Maastricht, they did an analysis on endothelial cell loss. Also over time, and it's very comparable actually from the cachet lens that this paper from Thomas Konen shows. So it's very interesting that the artisan lens is still on the market and still being used, while the cachet lens was taken off the market. And the question then, I think that's a good question, was it justified that the cachet lens was taken off the market, or in hindsight, could it still have been used? And I think that well, I never implanted the cachet lens, and we talked it a little bit before this session, this webinar. I think I was just an ophthalmologist. I just graduated from my residency. There was a lot of discussion in my hospital whether this lens should be used because of that experience in the past. And what I still remember is that sizing of this lens was an issue, and that not everybody did the good sizing, and that gave a lot of problems, and that gave the cachet to some people a very bad name, while many people had really good results, which is also shown in this paper, that many people had very good vision, very good results, and most people did not have side effects of this lens. So yeah, in hindsight, yeah, I'm not sure whether it was justified that the lens was taken off the market, although Alcon, of course, they took it off the market by themselves. It was their initiative.
I think also rotation of the IOL was a little bit frightening at that time, although the last studies does not show a relation between endothelium loss and the rotation of the IOL. Another cause, I think it was also the fact that I think this IOL, the first model, has not the mark for positioning the IOL. So sometimes it could be upside down, and there is an angulation in the haptics and maybe a vault of the IOL, and that also could cause some initial problems.
Okay, so I want to ask another question to you. I know that you're not implanting cachet lenses, but you are implanting ICLs, right?
Yes.
Okay, so when a patient with an anterior chamber lens comes to your clinic, what are your red flags when you see a patient like this? What are you searching for in the biomicroscope or in any other evaluation?
Well, of course, we need to have a very perfect morphology of all the anterior segment. And if we see some loss of pigment, if we see some iridosynechias, any tyndall flare, something, of course, all of these need to be checked. And do, of course, the specular microscopy. But we need to do a very good follow-up. We need to always check the same zone. So it's not easy to do the follow-up of these patients properly, because we need to standardize very well the measurements, and sometimes in the clinics is not easy to do.
I understand. How often do you see your patients with anterior segment IOLs?
Well, the recommendation is if we have like 18,000 cells, we need to check every 6 months. If not, and we have not an annual loss more than or near 2%, one time of a year is enough.
Okay, thank you. And I would also like to ask a question to Dr. Reus. So as we all know that small eyes increase the risk of endothelial cell loss, but the mean anterior chamber depth in this study in the explanted group was 3.12, and it's not very low. So, and also in Asian population, they have a tendency to have more loss. So when you have a patient that you might think that he is under more risk, or when the patient has a slightly smaller anterior chamber diameter, do you wait longer for the second eye to operate? And in a standard patient, for how long do you wait for the second eye?
Oh, well, that's a good question about the anterior chamber depth, because in the paper it's not clear that there's a strange thing going on in that the anterior chamber depth was correlated with explantation rate, but was not correlated with time of explantation. So you would expect if anterior chamber depth was causing endothelial cell loss, that if your anterior chamber depth is very shallow, that you would have an earlier explantation, but that was not the case. So in this paper, I question whether the decision to explant the lens was also based by the ophthalmologist that the anterior chamber depth was shallow, and that he or she was thinking, well, this is a risk, so I'll take it out earlier. That's very, very interesting why ACD was correlated, but not in time of explantation. That was strange. So that's a thing that I was thinking whether that could also have been caused by sizing of the lens, whether the sizing was good. I could not see any correlations made between the size of the anterior chamber diameter and the lens that was implanted, and whether those lenses were explanted earlier. that was something that I saw that in the methods they gathered the data, but I didn't see any statistics on it. So that would be nice to see whether sizing was an effect on or affected the chance of having to explant the lens. With regard to your question, it's a good question, but personally, I don't implant phakic IOLs.
Well, I'm going to ask Professor Ribeiro that.
I take them out.
Really? Okay. You're going to turn back to that.
As I said, I use mainly the ICL IOL, and right now with the intraoperative OCT, if it's not a toric IOL, it could help us to have a proper volt for the IOL. So it's more easy now if it's not toric IOL, and if everything is weak, it's more or less the time to operate the second eye.
Okay, thank you very much.
I thought I'd ask a question more broadly about devices and safety. Because of course, as ophthalmologists, we implant a lot of devices, each one of us every year, probably hundreds or thousands. And so, and clearly sometimes the rate of an adverse event is quite rare or not very common. And therefore, there's this sort of, it draws some attention to the mechanisms of reporting for when there is a safety concern about a device. What is the role of the ophthalmologist? What is the role of the manufacturer? And is there a role for another body to aggregate this data to find patterns quicker? And so it's quite a broad question, but I know this paper, it touches on safety, and so I thought we'd have a discussion on this. Dr. Reus, why don't you start? What are your kind of thoughts on devices and safety as ophthalmologists?
When you start implanting a new lens, and I regularly do that, I mean, it's nice to be asked by tech firms that they developed a new lens, and would you like to start using this lens as one of the first. But there's also, and that's nice because you're at the forefront of this technology. But there's also a risk that I mean, you're treating a patient, a human being, and you have the obligation to take very good care of them. So it's also a risk if you are at the forefront of this technology that you may implant something that in a year or a couple of years appears not to be as safe as once thought. And it's very important I think in these technologies to follow up these patients and do very close follow-up. Many of these, these large companies like Alcon or J&J Vision, they have very large, the studies that they do, they have a good, very, very long follow-up of these patients for safety reporting. But also think that ophthalmologists are important in these safety reportings, that if you do find an adverse event, that you report that. I mean, in the Netherlands, in our hospitals, if we see an adverse event from something like this, we have to report that to our own hospital. And of course, depending on the severity of the adverse event. But if you have a smaller adverse event, you have to report that in your hospital. If it's very severe, you have to report that to the, how do you say that in English? There's the government, they have the healthcare inspection. They have to know that such an event occurred. And of course, that's also true for medication. We have a body responsible for that, and you have to report that. And you can also report that to the manufacturer themselves, and they then go to the bodies that in the local country that are responsible for gathering these data. I do have to say that if you report something to either the company or the government, it takes a lot of time.
Yeah. Yeah.
Because you think, well, I'm just reporting that this and this happened, and you get loads of documents that you have to fill in, and it's not. Well, you then wonder why did I do that, and that's of course that's not the good attitude, but it's a lot of work. You have to be aware of that happens. In the Netherlands, there's a discussion on an implant registry. And that was for the breast implants. They already set that up, and we're now in development. Of a registry for all implants, so also the intraocular implants. And I think that's a good thing, because then you can see which implants were explanted, and if certain implants have a higher risk of explantation.
Yeah, that's a really helpful response. Professor Ribeiro, can I ask you a slightly related question? Following on from what Dr. Reus said, clearly in the UK there are similar processes to what Dr. Reus mentioned in the Netherlands. I'm just thinking, if, for example, you have a new implant or relatively new implant, and you have, and presumably they have a big influence in those early studies, they tend to be industry sponsored. So I'm thinking now a device is released, for example, it's in different, maybe 10 or 12 different countries, and each of which have got an individual reporting system. And so my concern is, in order to detect an adverse event early, how important is the collaboration? In other words, how important is it that those different countries are able to connect the dots and see an adverse safety signal early? Does that sort of system exist, or what's your feeling?
Yeah, exists, but it's not an easy channel.
Yeah.
If you understand me. Of course, if we report an adverse event unknown or known but severe, the manufacturer has to report to the European
regulator.
But there is an institution, European, responsible for that. And that is an obligation.
Yes, okay. Okay, good. Do you think there's a role for ESCRS or any sort of similar European body to have a registry, or do you think there's enough? Do you think that's already sort of accounted for? Do you think there's any role for anything further?
What I think it exists, but is not visible. It's not an easy channel. And maybe if it was, and of course, it's a lot of work, of course, but we can understand that if some case like this is reported, everything needs to be checked, and this explains the lot of work we have, and is necessary. Yeah, but that should be an easy channel to do it. Yes.
Of course, with other implants, we use things like opacification of IOLs, and there can be various problems with various devices. And I guess I just want everyone obviously listening to sort of understand who would they report it to and what happens with that data once it goes off. And this is a really useful case study in what would happen in that scenario. And of course, in this case, the manufacturers voluntarily removed it from the market. But presumably there's probably a mechanism for them to be made to do it if it was considered sufficiently severe or an adverse effect.
Yes.
And I think that ESCRS also has a role in it, in that sense that I mean, we have the congresses where you can do the free paper presentations and stuff like that, and that's also a podium where your experience with these kind of lenses, you can make them known to the world, and that's also a very good role for the ESCRS to have a role in that. I think with a registry for how these lenses are going. I mean, I do think that there is a big role for the governments themselves, because it's a regulatory role, and I don't think that as an ESCRS you would like to want to have that. I mean, we are here for the ophthalmologists and the patients. Although what is interesting is then, I mean, we have a EUREQUO, the registry for cataract and refractive surgery. If you would have a link with the types of lenses that you use, I mean, you could have warning signals that a certain subtype of a lens might have more problems than the other one. Although, of course, it's also very difficult. I mean, with these data, do everybody that uses this lens, do they report their outcomes, whether good or bad? And how did they use these lenses? Were they used properly and stuff like that? So if you do analyze such registries, I mean, you have to be really careful with your interpretation of whether it's a biased reporting or a misuse and stuff like that. So it's also very difficult well, you have to be very careful in your interpretation.
And I think Professor Ribeiro did comment on the fact that there are different standards for measuring these different parameters, for example, endothelial cell count. And of course, that might make it more difficult to compare different centers and different implants if they're measured in a different way. So perhaps that's another sort of hurdle towards getting a safe, robust system for reporting adverse effects, perhaps.
Well, that's also the report from the Maastricht University from Rudy Nuits and his group, that they reported on the artisan lenses and artiflex lenses. And one of their discussion points was that over time, the way that they measured endothelial cells changed over time. What I understood from the current paper that we discussed is that the way the cornea was measured stayed the same over time and in all clinics that participated. So that's a very good point of this paper.
Thank you. Basak, do you have any further questions before we wrap up?
Actually, the discussion is in such a perfect place. How you talk about the registries and EUREQUO is, this is where I want to stop the discussion, and we can go to the poll, I think.
Yeah, it's been a very, very interesting discussion. We could go for longer. It's been great. All right. So perhaps now I'll pick up the poll. Okay, lovely. So just some questions to finish. So after you've heard about the paper and reviewed these data, would you be happy to implant an angle-supported phakic IOL for myopic refractive correction? So not necessarily this particular lens, but just any angle-supported phakic IOL. Would you be happy? Yes, no, or unsure? All right, so one individual thinks yes, they'd be happy. 8 think no, and still 5 unsure. So not everyone thinks no. So there is still a place perhaps for angle-supported phakic IOLs. So this is about management of patients in this group. So would you prefer to observe a patient with an angle-supported phakic IOL who has an endothelial cell density of less than 1,500 cells per square millimeter, or would you undertake surgical explantation based on the findings of the paper? And again, we talked about this difficult patient management decision. So would you observe that patient? 2, would you explant the phakic IOL? Or 3, are you unsure? Yeah, so 50% say they would observe, 29% say they would explant the IOL, 21% would be unsure. But of course, that partly depends on the patient in front of you and what they want. So it's a slightly, leading question. Okay, and just to finish off, which of these refractive corrections do you feel most comfortable performing on your patients? A clear lens extraction, phakic IOLs, and that's all of the different types of phakic IOLs, or any of them, LASIK, or none of the above? Okay, so obviously LASIK's the clear winner here, but still people performing clear lens extraction, of course, and phakic IOL. So that's useful to know. All right, so then over to you, Basak, to finish off.
Thank you so much, Imran. So tonight we discussed 10-year safety follow-up and post-explant analysis of Cachet Phakic IOL with our panel. Before giving the word to Imran for introducing our next event, I would like to take this opportunity to thank our panel for sharing their time and wisdom with us tonight. And I would also like to remind you that a recording of this episode will be available within 24 hours on the ESCRS Facebook page and YouTube channel. Imran?
Lovely. So yeah, please do join us and make a note in your calendar. Wednesday, the 3rd of February, 2021. We're going to be talking about this paper, Visual Outcomes in Corneal Biomechanics after V4C Implantable Columnar Lens Implantation in Subclinical Keratoconus. So that should be quite an interesting paper, recently published. So make a note of that and please join us next time for the next episode of IJC. And yeah, we'd just like to thank our faculty. It's been a really lovely discussion and I've really enjoyed it. Not just talking about the paper, but also the wider context of safety in ophthalmology with these implants. So thank you very much, Dr. Reus, Professor Ribeiro. It's been a real pleasure having you on our show.
Thank you both and congrats for the format, the Journal Club. It really is very, very good.
Well, we'd happily have you back.
Well, thank you very much as well, and also agree with Dr. Ribeiro. You do a very good job with this journal club.
Thank you so much.
Thank you.
Bye.
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 Have fun.